podcast by respiratory leaders for respiratory leaders. This is RT Sidebar. Stay tuned. Hello, hello. Welcome to RT Sidebar. We are recording live here on 16 September. And if you would ever like to be part of the live recordings, you can register with the link in the show notes. But with us here today, we have Mike Hess, who is the Director of Advocacy at the COPD Foundation. Mike, thank you so much for joining us on the show.
Thank you for the opportunity. I really appreciate being here.
How did you get into the profession that is RT? And then I feel like it's kind of unique to then get into the COPD Foundation. So how did that happen?
Yeah, my story of getting into the profession is probably sadly common. Long story short, the waiting list for nursing school was too long. I was a late bloomer, wasn't sure what I wanted to do with my life. Married a nurse and was interested in the story she would tell in the ICU. She was a trauma ICU RN. Thought that was very interesting. Loved all the medical shows, ER, stuff like that, and thought, well, okay, I'll give that a try. But it was going to be about 2 years before I could get into even start the nursing program. We had just had our now oldest, and I thought, well, I that's a long time to wait, plus the time to go through the program and everything else. And as it happens, our oldest was a preemie. Spent about a week in the NICU, surfactant, chest tube, vent, that whole 9 yards. And I remember thinking back, I couldn't figure for the life of me how anybody could figure out what all those little squiggles on the machine meant when she was intubated and everything else. So right next door to the nursing program was the RT program, and they could get me in right away, and I never looked back.
Wow. Yeah, that I feel like a lot of RTs have again, yeah, similar stories. We also are joined by Matt, who worked in the NICU for a period of time. Matt,
I
thanks for being on.
thank you. I love the NICU. It's the greatest place in the world. One of the best neonatologists I ever met was Tom Keyser, and said there would be no medicine if there wasn't neonatologists, because if you don't save them when they're little, they can't be saved later in life. So the most important medical specialty is neonatology. So shout out to Mike McQueen, because he would 100% agree with that. So Mike, tell us a little bit about your journey. So you chose RT because you couldn't get into nursing like that. Then what happened? Because like Anna said, your trajectory is a little unique. So I'd like to hear how it led up to where you are today.
Sure. Well, yeah, I started in, as many of us do, in acute care. Thought I was going to be a vent guy. Really enjoyed working ICU, whether it was trauma, burn, medical, cardiac. Enjoyed working in the ER. Did not like the NICU, so thank goodness for RTs like you. It's not that's a little too twitchy for me. You look at one of those kids wrong, and all of a sudden their BP is out of whack and everything else. That was a little too much for me. But so I did that for a while, and then career changes happen, and ended up being or a career path change happened, I guess I should say. Ended up working at a relatively small facility near my home. Working night shift. It was we probably had 12 beds. It was primarily an inpatient psychiatric hospital. Not much in the way of action at night, and for a while, it's what a lot of people think is a dream job. You can kind of sit around watching movies all night or playing games or whatever. But eventually, you do get kind of bored, or at least I did. And so I thought, trying to figure out, I started looking around at what else was out there. And at that time, I actually had an opportunity to record some continuing education videos that I
Mhm.
actually have no idea whatever became of them, but they said, if you do 4 of these videos, we've got a contract from somebody. If you do 4 of these videos, we'll bring you out to our studio in Monterey, California for a couple days and we'll record them out there. If you do 8, well, you can bring a companion. So I thought, okay, oh yeah, that sounds like a nice trip for the wife and I. And so I said, yeah, sure, sign me up for 8. And so then I start doing the nitty gritty of it. And, again, I was thinking, well, okay, what am I going to talk about? ABG is pretty obvious, ventilator
Mhm.
management, pretty, the nuts and bolts kind of stuff. And then you start getting down to 7 and 8, and it's like, okay, now what? Well, I guess I'll talk about COPD. And in the process of doing research for that particular module, I realized what an absolutely terrible job we were doing as a healthcare system, teaching people how to manage their COPD and
Mhm.
caring for them and everything else. And at the same time, I had just been reading about the readmission reduction program that Medicare was about to implement, or had
Okay.
just implemented, and was about to add COPD to. And I thought back to something I had once heard a guy by the name of Gary Kaufman say, who's if people don't know Gary, he's an excellent, he's been a leader, and he's done everything, and he's a really insightful guy. He says, if you really want to have an impact, whatever career you're in, if you really want to have an impact, you've got to learn what's keeping the C-suite awake at night. What are their problems? What are their pain points? What are they
Mm.
thinking of? And I thought, well, okay, we're doing a bad job with COPD, and we have a lot of readmissions. They're going to add this to this penalty program, and all of a sudden, we're going to be talking about real money. So if I can kind of learn more and be the COPD guy,
Hmm.
then when things are rolling in, they're going to eventually, start calling upon me, hopefully, and that's how I can be a big shot. And so I started with a Facebook group, just, again, teaching people, it wasn't medical advice, obviously, or anything like that, but people could come and ask questions and get some peer support. And then they would have somebody who actually knew the answer to give, to make sure that there was no misinformation or anything like that. And that kind of grew for a while. And then I decided, well, if I'm really going to have an impact, whatever it is, I need to get a bachelor's degree. So I went back and did that, got a bachelor's in interdisciplinary health services from Western Michigan University.
Nice.
It's designed to be a complement to an associate's degree. So
Hmm.
whatever associate's level thing you get some healthcare administration, you get some informatics, you get all that kind of stuff. And then I thought, well, I'm not going anywhere at this facility that I'm at. So what else can I do? And as it happens, we had a growing medical school here in Kalamazoo,
Hmm.
and they had a primary care office, and they kind of covered both of our health systems. So it was a really nice opportunity to kind of be in the neutral ground. And I cold emailed the dean and said, "Hey, I'm some random guy you've never heard of, but here's an idea for you. Let's manage this in primary care. Let's see what we can do with that and actually do this kind of care coordination and everything else." And much to my surprise, he actually emailed me back later that day and said, "I'm going to have you talk to this doc, and let's see what we can put together." And I just about a year later, I saw my first patient as an outpatient RT, doing spirometry in the office and care coordination
Hmm.
and teaching people how to use their inhalers and doing referrals and everything else. And that was my journey there. I thought that was going to be the be all end all. And then 2020 happened. I think we all know it. And the upside to that role was there aren't many others like it. There's not a roadmap or
Hmm.
anything like that. The downside is there aren't many others like that, and there's no roadmap, and nobody knows what to do with you when you deviate from the roadmap that you're drawing as you go. And so I was for a few months putting on the bunny suit and doing the old school COVID tests that go all the way into your brainstem, and scanning foreheads at the door and everything else. And I thought, well, this is just not awesome. And fortunately, the opportunity at the foundation came along, and I had been a volunteer with them for a while. And I thought, well, even in a perfect world, COVID free, this would be a tough opportunity to pass up
Hmm.
because it's a natural evolution. And that's where I'm at.
What would you
Holy.
say the mission is of the COPD Foundation?
Yeah.
Um, I'll probably get in trouble with my boss because I don't have our official mission memorized. But we're a nonprofit patient advocacy organization.
Mhm.
What we try to do is, until we have a cure for COPD, we want to make sure that people have access to the most appropriate therapies. We want to make sure that healthcare policy represents the best interests of the COPD community. We want to make sure our friends in the industry are supporting our patients, and frankly each other, because rising tide raises all boats. And we want to keep moving towards better treatments and a cure for COPD, for bronchiectasis, for all of these related lung conditions.
Well,
So,
that is a perfect segue to two questions. I am in orange, and you are wearing this lovely tie-dye shirt. Do you mind to our listeners, do you mind describing what it is you're wearing and why we're wearing this?
Yeah, absolutely. So one of my key initiatives at the foundation is what we call Oxygen 360, where we're trying to do a lot with modernizing oxygen therapy. And a big part of that is a new event that we started last year with the second annual observance coming up this year called World Oxygen Day. We observe it on October 2nd because that's O2. We figured that was pretty memorable. And in association with that, one of the things we do to support that is we have our own merchandise store because, who doesn't have a merch store these days, right?
RT Sidebar.
And
We do not have a merch store.
well, that'll be for season 3.
Season 3. There's
Season 3. Season 3.
And so yeah, this is we have t-shirts, we have sweatshirts, we have water bottles and coffee mugs and pins and all kinds of stuff, with a portion of that going right back in to support our efforts. And we support a couple of our other initiatives there too, our World Bronchiectasis Day that we have, our Lace Up for Lungs campaign that we do during COPD Awareness Month, to get people to be active. So go ahead and check that out.
Yeah, I'll put the link in the show notes so that we can keep supporting the great work that you're doing at the COPD Foundation. But um, so today we really want to talk about the sorry state of oxygen therapy in the US.
Yeah, let's talk about that.
Yeah.
Yes.
How did we get here? What's going on with oxygen therapy? Why do we have a World O2 Day? Like, why do you think that's necessary?
Well, it's interesting because before I joined the foundation, like I said, I was the inhaler guy, and working in primary care, I kind of knew that it was rough. I knew that there was this concept called the competitive bidding program that kicked in a little over a decade ago. That basically the assumption was a lot of our friends in the DME sector were just kind of raking in money hand over fist. And in an effort to save money for Medicare, because, we do as much as we would just love to have every piece of healthcare for every person ever, we have a limit and we have finite resources. And so their thought was, well, if we can reduce some of the spending that we have, make it more efficient, we can make our programs a little bit more sustainable. Good in concept. The execution left a little bit to be lacking. Basically, what they did was they divvied up the country into various regions and ask companies to submit bids for what it would take to pay for example, oxygen therapy, the equipment and everything else. And, so they literally turned it over to the lowest bidder, which was very unfortunate because it was rough. And I say that not even as an opinion, but they actually had to stop and restart the program like 2 or 3 times before they even had something that was even workable because of problems with the bidding process. And it was flawed in execution from the get-go. And that was bad enough. And that's usually the point that people, that's what is usually considered the tipping point. But as I've done some other research and talked to some people who have been doing this a lot longer than I have and everything else, the roots of this problem actually go back into the 80s. I think it was 1980, or no, excuse me, 1997. No, must have been 1987. I have a whole timeline and stuff, and I've been looking at numbers all day, so they're all kind of going together. But yeah, 1987, that's when the first budget cuts started in home medical equipment. And they started making things like delivering and servicing liquid oxygen a lot less practical from a business sense. Because they turned it so that instead of reimbursing a company for how much oxygen they distributed, they gave a set amount, regardless of whether you used a concentrator or tanks or liquid or whatever. You got a certain amount of money. So if you've got a modality that costs more than your reimbursement, you're probably not going to offer that modality anymore. And then it's just been kind of a death of 1,000 paper cuts for the next 30 years or so.
So wait. And I'm an inpatient guy, never been an outpatient guy. I know about competitive bidding. I have to go, okay, who do they get? Who gets the chance? Are you telling me that citizens of this country that need oxygen struggle to get it?
Oh, absolutely. We get questions all the time at the foundation. I need I need something portable that will give me 4 liters of continuous flow, 5 liters of continuous flow. What kind of
Okay.
concentrator can I get for that? There isn't one. You used to be able to do that with, for example, the liquid oxygen. That was a feasible option, but access to liquid oxygen has dropped roughly 90%, even just
Yeah.
from the beginning of the competitive bidding. And again, it was already on a slide before that. So there are people, and I actually had this conversation with a woman at the Pulmonary Hypertension Association meeting I
Hmm.
attended recently. She has pulmonary hypertension through, and again, this is not something, she wasn't a smoker or anything like that. There's no possible justification. I know there's a lot of stigma and a lot of people say, well, they did this to themselves, which is a whole other rant I could go on.
Hmm.
But this is somebody who has this condition, really needs 7 to 8 liters continuous flow at baseline. And then, whenever, as soon as she starts moving, that goes up into the double digits. And feels often confined to her home because the only thing she
Oh,
can do is haul around a wheelbarrow full of oxygen tanks in order to get by. And she's very frank about that. We'll have a little featurette with her coming out on World Oxygen Day, as she's telling her
okay.
story. But she's yeah, and she's trying to raise a family, and she's trying to stay active in her community and do all this stuff. But we tell people to be active and stay healthy, and then we give them these boat anchors, or we confine them essentially to their homes. And that's just too bad, apparently.
That's what I was thinking. So we want oxygen patients to exercise more, but we literally created an anchor where they can't. They because we don't want to pay for the modality that's going to make them mobile or make them human. Is that really
No,
what's going on? Holy cow.
to a degree. I mean, to be
Yeah.
clear, some of the existing equipment does work quite well. I will say that one of the highlights I often use is a gentleman by the name of Russell Winwood, who
Okay.
is an Australian gentleman. Was diagnosed with COPD after a heart attack. Actually, he was not a real fit guy, and he's very open about this. Loves to tell this story in his fantastic Australian accent. He talks about how that was his wake up call.
Hmm.
He stopped smoking, stopped eating poorly, all that kind of stuff, started getting a lot healthier, and has started running marathons. And so here's this guy with stage 4 airflow obstruction, chronic hypoxemia, who in about 10 days from when we're recording this, I believe it is going to be running in the Berlin Marathon, which is his 6th marathon. This is the last of the major world marathons that he's doing. And he has a co-runner who carries along a portable oxygen concentrator and and the batteries and everything else, and runs alongside him. And he does these marathons on oxygen therapy. And he's
Wow.
Yeah. So to for a lot of folks, the equipment can be appropriate, but that's yet another angle to this is we make no effort to match those people. You get what the DME has. And again, this is not disparaging on DMEs because that's all they can afford to give these days, but
Hmm.
you get what they've got. And if that works, then fantastic. If it doesn't, then maybe you can go from tanks to a portable concentrator, or, again, just there's some tweaking you can do with that. But if those small tweaks don't fit your situation, then you are literally out of luck.
You mentioned to me before we started recording that the patient Mary,
Mhm.
uh, who was like, "How am I going to be able to work with the what has occurred?" And the provider said something like, "Why do you need to work? Like you have COPD. Like you're not." Do you mind explaining that
Oh yeah.
story? It's way better from
Um,
you.
Yeah. Mary is a really good friend of mine. She and her sister run a nonprofit organization called Running on Air, that does a lot of this advocacy work. And they both have primary ciliary dyskinesia, and they both have bronchiectasis secondary to that. And they have since both started on oxygen therapy. And when the first delivery of her tanks arrived, she said, well, I think it was her sister actually, said, this is not enough to get me through my shifts for the rest of the week. She was a nurse practitioner. And I need to go to work and I need to have a certain number of tanks. And the delivery driver said, what are you talking about? People on oxygen don't work. You don't, that's, and sadly, that's far from the only story like that I've heard. Again,
Hmm.
we at the foundation, we get a lot of patient reports on stuff. We've been told that, well, my supplier told me that travel is a luxury. That's optional. We just, it's, again, we're literally confining people to their homes because of ostensibly well-intended, but ultimately flawed policymaking, and
What
everybody's hands are tied.
what happened to Mary? I'm curious as like an NP like who can fully understand her disease state or condition and the ability to advocate for herself. Like, wh- yeah, please tell me there's some sort of light at the end of this tunnel.
Oh, absolutely. I mean, they're both, Mary and her sister are both doing quite well. And again, they run this advocacy organization. Mary is kind of the face of it most of the time. I actually just spoke with her at a conference we got to present together. But I would say to people, look, I can explain your disease to you. I can explain the pathophysiology. I can explain the therapies. I can tell you probably why you're out of breath, or X, Y, and Z. I cannot tell you I know how you feel, because I don't, and I probably never will. It's very easy to say that to somebody. It's like, oh yeah, I know how you feel. I ran for, I jogged for 10 minutes and I got out of breath. And so, I know how you feel. But for most of us, that goes away. We don't know what it's like to be breathless all the time, to have an uncontrollable cough that you want to get up and leave kids or grandkids concert or church or whatever, function you're attending. We don't have that experience. And the only people that do are people in that community. And so I think it's incredibly valuable and powerful to give presentations with both voices so that we can kind of give both of that context. So, and Mary is a great person to do that. She's put in boatloads of effort into not only advocacy, but some research. She's compiled some great resources about portable concentrators and their different performance characteristics and everything else, and then just provides all that information to the community. So yeah, there is definitely a light there. They're thriving, and they're using the situation to whatever advantage they can to help make the situation better for everyone else.
And the Berlin Marathon, that is the coolest thing. That I think that's like 3 weeks from now. It might be even just 2 weeks. So wow, good luck to Russell. That's like a huge shout out to him.
Yeah, it
Um,
was really exciting. If I can, I'll just shoot one
yeah.
more thing in here. I've been talking to Russell for probably the better part of a decade now. He was one of the first people I came across as I entered the COPD world, and I actually finally got to meet him in real life. I think it was last year when he ran the Chicago Marathon. I live about 2 hours outside Chicago, so when he said he was going to be there, I was like, okay, we've got to go down there. So I packed up the family and we went down for an overnight, and got to meet him and his wife, and just had a wonderful time actually meeting in person for the very first time. So he's a great guy. Can't say enough good about him.
Wow, that's awesome. If he runs New York, you have to let me know so I can connect with him. I think it's so cool as you give a voice to Russell, to Mary, to all these patients, as you said, like to both sides. You're really navigating the healthcare landscape here, and the COPD Foundation does such a good job with I don't want to say this wrong, but it's like a portal that you can post and ask questions and comment on. And like there's these massive threads. And I think it's so cool that you started with these Facebook groups and it's almost like you've created a social network. Do you mind talking about that a little bit?
Yeah, absolutely. I can't take too much credit for the one that the foundation has, but we are very proud of we call it COPD 360 Social. It's an integral feature of our website that people can come on and ask any questions, or we've got a lot of traditions. Like we've got one person that posts a recipe every single day. We've got Fluffy Friday. People post pictures of their pets. So people do that. They can again ask questions. They can look things up. We have surveys from time to time, all that kind of stuff. And it's really just reminding people that they are not alone on this journey, because a very common trajectory for a lot of these folks is they'll come on and say, hi, my name is whatever. My doctor just told me I have this condition. Then I went to Google, or I went to search engine of choice. And I found out that I've only got 2 years to live, or all that kind of stuff. Help me. What's really going on? And they're met with dozens of people who are right there with, okay, well, first of all, let's not go to Google for that because there's not a lot of context there. But here's the deal. I've had COPD 4 or 5 years, 10 years, 20 years. It's not always what you think it is. And so you get that very valuable peer counseling. And then they can also ask questions about oxygen, about medications, about procedures like bronchoscopic lung reduction. What does the future hold for research? We like to try to do whenever there's a major respiratory conference like American Thoracic Society, or we just had the European Respiratory Society, AARC coming up. Whenever we have any of these big respiratory conferences, we try to do some kind of summary written in accessible language, so that people can kind of understand this is what the research pipeline looks like. This is what's out there, because these are folks that haven't had a lot of hope for a long time. There's been a lot of what we call therapeutic nihilism, where your prescriber is like, well, you've got this condition, there's nothing we can do about it, you're basically just going to run out the clock, so here's your inhalers, and oh, by the way, quit smoking. um, and that's that. But in the past few years, we're very fortunate to see a lot more investment in therapeutics, and moving on with that stuff, so we're able to give people hope and kind of brighten their day a little bit, and again remind them that they're not alone.
Mike,
What?
I'm gonna push the button. You ready?
Here we go.
COPD has the stigma that you did it to yourself, but you just described Mary, just described Russell, just described. We were at Maryland, DC last week. You and I were together. We met a gentleman that had alpha 1, which is
Mhm.
a COPD. I know this statistic kind of, but I know you know it better, that COPD is number 4 or 5
Mhm.
on the mortality list, but number 56 in research. There is a stigma. And to me, it feels like that seeps into the lack of hope of the patient. So that's the button I want to push. How did this happen? We have so many citizens that have COPD, but yet they don't have the advocacy that other diseases have. So I want to push that button because I want to hear
Yeah.
what you got to say about that.
The overarching issue is, for whatever reason, we I would even go so far as to say a species, don't really care about our lungs. We know a lot about our hearts. We know
We
we
do.
know what to do if you're having a heart attack. We know what to do, what is heart health. Oops, we know what is heart healthy and all that sort of thing. We know a lot about our brains. We know signs of a stroke. There have been fantastic campaigns about recognizing strokes, and what to do and everything else. But of the three organs that I would argue are probably most essential in keeping you alive, your brain, your heart, and your lungs, we don't do anything about our lungs. We don't prioritize asthma research. We don't prioritize overall lung health, clean air, all that sort of thing. And so there's a baseline deprioritization of that. On top of that, in what we call high income countries, what we used to call the first world, the developed world, the leading cause of COPD is absolutely tobacco smoke. It causes about 80% of COPD cases, and obviously has a lot of other ramifications too. And that is something that we often have looked at as something that if you wanted to, you could just quit. You could just stop. You could just break that habit. And if you couldn't, then you weren't trying hard enough, or what have you. Um, and so that leads to this whole, well, you haven't quit, so you're still doing it to yourself. And there is almost as much wrong with that philosophy as there can possibly be, because first
Hmm.
of all, you've got 20% of cases that aren't caused by smoking. They're caused by genetics, like alpha 1. They're caused by occupational exposures. They're caused by, as we're learning more and more now, suboptimal lung development early in life. Some people
Bingo.
never meet their ideal projected lung development because of social determinants of health or adverse childhood events or whatever. And so as you start getting into the time where you have age-related decline in your lungs, you get into that COPD space again. And Then we look globally and we see that in many parts of the world, tobacco smoke is not the leading cause. It's biomass smoke exposure because we're
Mhm.
still using biomass fuels for cooking and heating in a lot of the world, as well as rural parts of our country. I mean, there's
Mhm.
parts here in Michigan, parts of the state where people use entirely wood burning stoves for cooking and heating, and therefore they get that exposure.
Mhm.
Um, so we have that stigma that has come from a baseline stereotype of deprioritizing the lungs. And then on top of that, we just haven't done any, so that hasn't been a research priority. And so we haven't learned as much as we should, and we haven't had as
Mhm.
much activity as we have in other organs. And the last thing on top of that, and this might push a button, there's not a medication that can fix it. We have great medications for metabolic conditions. I myself have
Mhm.
been on GLP-1s for a while now. I've benefited from those. And so when you have that kind of thing, you've got industry partners that are willing to throw a lot of resources behind that
Mhm.
and advocacy campaigns and everything else. But when your main treatment is basically, when it boils down to palliative care, you're fixing symptoms, you're reducing symptoms to improve quality of life and reduce exacerbations. That's not as sexy, and that doesn't drive
Mhm.
quite as much, I don't think. So
I- it-
we haven't had that partnership. I mean, we've got some great partners. I want to be clear about that,
oh,
but
absolutely. Mhm.
we haven't had that big spark.
It's interesting. You use the word sexy. That's the term I always, the heart's sexy, the brain's sexy. I never really looked at it. Is that really the lungs just aren't socially that sexy to talk about? I mean, it does make sense. It really does. But there has been some improvement. What are
Yes.
those? What are those improvements? What are those things that we should be doing as therapists, as clinicians, as a society to improve the outcome of this big portion of our citizens?
Well, there's access to medications is absolutely a big part of it because
Hmm.
again, that's kind of the first step, and there's some low hanging fruit there. Again, that talk about oxygen with Mary, but I also gave a talk about selecting the right inhaler, because depending on what study you look at, somewhere between 40 and 90% of people don't use their inhaler properly, and it affects their dose delivery. And so, we're just like with oxygen, we're giving people a tool, not teaching them how to use it. It's not working for them. And then they start wondering, well, is there something wrong with me? Am I worse than I thought? What's the
Hmm.
problem here? And so we as RTs, we should never pass up an opportunity to teach. And I know that's easy to say because it's easy for me to spend everybody else's time and money. But if you're in an ER, or if you're in whatever setting you're in, you can take a minute and find out if that person knows how to use their stuff, and if they have any questions about it, and or how to connect them with resources and everything else. That's absolutely something that we can do. The other thing we can do is honestly get involved politically, for lack of a better term. We
Hmm.
have every year, AARC at the very least has some kind of advocacy initiative, the Hill Day, you may hear it called. This past year, they've been working with, actually the past couple of years now, among other things, they've been working with organizations like the COPD Foundation and about 2 dozen other groups, to reform the things that are going wrong in oxygen therapy. And for the first time in I don't know how long, if not ever, we actually have a bipartisan bill introduced in both parts
Hmm.
of Congress called the SOAR Act for supplemental oxygen access reform that actually does provide better reimbursement. It puts the patient at the center of care and gives them a louder voice in what equipment is selected and everything else. And probably for this audience, the most important thing is, for the first time, there would be a statutory reimbursement element for RT services in the home. They would actually be paying for a respiratory therapist to go out and teach somebody how to use their equipment. And that's really important because not only is it great opportunities for us as a profession,
Hmm.
it's great for the patients. Before the pandemic, even the American Thoracic Society put out study results that said, I believe it's about 68% of people who get oxygen equipment are trained how to use it by their delivery driver. And now I
Oh
love my
yeah.
delivery drivers. I mean, this is not, it's not bad against them or anything else, but that's not fair to them either, first of all. And it's not fair to the patient and the caregiver. It's not fair to the prescriber. It's not fair to anybody, but that's who the DME can afford to teach how to use the equipment.
Yeah. Hmm.
How can, to the RT directors who are listening, what can they do for World O2 Day and upcoming it's COPD Awareness Month is November, correct?
Yes, yes.
What can an RT director do in both October, so O2 Day, October, um uh 2nd, and then COPD Awareness Month?
Yes. So we have a great social media kit that our fantastic comms department has put together that has a lot of pre-made resources, including social media posts. We actually just added some 8.5 by 11 posters. We had people keep asking, well, hey, we're going to have a little table. Like, can we set up can we have posters or anything like
That's
that? And we
wonderful.
thought, well, I guess we should make that. So we've got those available. We've got, again, pictures that you can, add to social media posts. We've got our messaging information on there. It's very easy to use. So at the very least, you can post those things, share them with your staff, share them with your C-suite. Maybe we would love to get some hospital systems and healthcare organizations behind things like the SOAR Act and everything else. And those, I think you can get the link in the show notes, or you can always go to worldoxygenday.org. That's kind of our homepage for that, and access that, and as well as our newsletter and everything else. So those are the easiest things to do. We're putting together some videos and things like that, having people say things like, hey, just happy World Oxygen Day, just getting those messages out there. And then as far as oxygen stuff goes, again, remembering to participate in these advocacy efforts. We're going to have a
Mhm.
big call in on October 2nd. We're trying to put that together so that people can contact their legislators and get them to be co-sponsors so that we can get this thing hopefully across the finish line before the end of this
Mhm.
session of Congress. And we're turning World Oxygen Day into kind of a year-long campaign because we know that these are not things that we can address overnight or anything else. And so there's a lot internationally that's going to be coming out next year with oxygen. The Lancet Global Health Commission, for those who may not
Mhm.
know, the Lancet is I believe it's a British medical journal.
Mhm.
It's been around for literally centuries. And they do a lot with global health, public health. They had a report about COPD and redefining COPD a couple of years ago that has really changed the face of COPD. And hopefully we'll see something similar with oxygen as they publish that report in early next year. The WHO is looking at things more seriously. So
Mhm.
we're probably going to see a lot more eyes on oxygen next year.
I
So we
love
want to build on that momentum.
all of these initiatives like bring so much awareness and education to it, and I think like as any leader in the hospital, like that's step one. And you've just given like so many examples of how to do that. I also love that you guys do have a merch shop. Like you could just get every RT like at your hospital, at your facility, get them something. Those funds go to an awesome organization and keeps furthering that awareness. So, and education like that to me makes a ton of sense. Like really easy wins that like is your responsibility, I think, as a RT leader, right? Like calling all barflies, like this is time to
Abs-
act. Like,
and Anna, you're our honorary RT. Danica Patrick, the NASCAR driver, was a big supporter of the COPD Foundation when she was still racing. Uh-oh, we're gonna have a
I
car
still
coming
have
out.
one of the
Oh, there
little,
it is.
I still have one of the
I
little
love it.
cars that they put together. This was a
Mhm.
industry sponsored. I guess I can't quite get it into focus, but yeah, we had the campaign, the Drive for COPD campaign,
Mhm.
and she was a huge integral part of that. And then yeah, we have that was some of the giveaways we had. So yes.
oh, cool. Do you mind talking about Lace Up for Lungs? What that is? Did I say that right? You mentioned it earlier.
Yeah, yeah. So Lace Up for Lungs is our
Yeah.
it's become our kind of keystone initiative for COPD Awareness Month, which is coming up in November. And basically it's just kind of tying, no pun intended, tying into the idea that you need to ideally stay active in order to maintain and maximize your lung health. So you lace up your shoes and you get out there, and even if it's for, 5 minutes a day or 30 minutes a day, whatever it is, That was one of the themes, I think it was 2 years ago, was we were hoping for people to be active for 31 minutes a day or 30 minutes a day for all 30 months or all 30 days of the month of November. So, it's really, again, trying to build that sense of community, and accountability to peers and everything else. Like, I'm so tired, but hey, my buddies are out there walking for me, so I better get out there too. So, um, and yeah, the other really cool thing that we've been doing, that I'll throw a plug out for, is an initiative called Harmonicas for Health that has also been around for the better part of a decade now.
Mhm.
Started with a grant from the Academy of Country Music, I think it's called, where we've put together, and this is another program run by an RT, Stephanie Williams at the foundation. This has
Mhm.
been her baby from the get-go. You basically we have these pre-made kits that leaders or whomever can order, at have a harmonica. They have all the notes for it, and they have some basic clinical information about COPD and why harmonicas are good for mindful breathing and everything else. And you just get together and you play the harmonica. You don't have to be good at it. You don't have to. Very
So
few
cool.
people are. I had a program for a while when I was back in my primary care days, and honestly, that was kind of the most fun thing I think a lot of people had, was they're used to going to a clinician who has all the answers and knows all the stuff and is good at what they do, and they see me fumbling up there just along with everybody else because I have no discernible musical talent, and so I'm there with my harmonica blowing all the wrong notes alongside them, and I think that really built a good sense of community when we were doing that. And it's also a good touchstone that we've been able to bring out to some minor league baseball games now. We had an
Oh,
actual a good harmonica group do a version of the national anthem and take me out to the ball game. And we've been able to contract with some of the minor league teams out there to have a little booth outside, and then we are their national anthem, and then we're their seventh inning stretch just to raise awareness about lung
so
health. So
cool.
we're really trying to do a lot more to get awareness out there and reduce the stigma and reduce that therapeutic nihilism I talked about, that
Mhm.
people can really live well with this condition.
Yeah, I think it's so clear what you're doing for this patient community, that's like you're not alone, and building an actual community, which is, I know, so difficult, especially like this population. I tried doing that in a different life with vapotherm access, and yeah, it's really, really, really tough. What would you say to all the RTs, but like also like younger Mike, who you had this choice that was like, let me just like check the box. I can watch my movie at night, or I can take your forehead temperature. And you were just kind of showing up and clocking out. What would you say to all the RTs out there, um, in regards to the COPD Foundation initiatives?
Yeah, my whole career seems to have been based on like trying, like falling into stuff, kind of like falling into I kind
Mhm.
of fell into RT, I kind of fell into COPD, I kind of fell into into primary care. I want RTs to know that these are opportunities that are out there. They're not accidents. They're not eh, it's not necessarily, it hasn't been anybody's initial plan before, but it can be now. A huge part of what I want to do is am ascending to the throne, so to speak, of being the chair of the ambulatory and post-acute care section at the AARC Congress this fall. Um, Part of what I want to do with that is get people out of that mindset that the only things I can do as an RT are at the acute care bedside. I can only do vents. I can only sling nebs. I can only do this. I can only do that because maybe I don't want to go into management and that's the only other career path I see. Or maybe, I don't necessarily want to go into sales or, those sorts of things. Maybe I should become a nurse because they have all those different career opportunities. But so many of those are also available in our profession. They are not as obvious and they are absolutely not as prevalent, but that doesn't mean that they shouldn't be or that they can't be. We need people who really want to get involved in a lot of these things to drive them forward. And that's kind of where I was. I wanted a little bit more out of my life than just kind of sitting there and waiting for things to happen. I wanted to do those things. I wanted to go out and build stuff and help other people follow in that path. I mean, again, I was a staff therapist. I'm not some kind of magical unicorn that sprinkled fairy dust and got all these positions open. I was a staff therapist. I was like everybody else, associates trained, just doing my thing. Happened to, see what the landscape was and how do I get from point A to point B. I think that's where a lot of people kind of fall down, because there aren't a lot of these roadmaps out there, and sometimes you do have to write them yourself, but they can be written. We do have so many care navigators these days. We've got asthma and COPD educators. We've got we put a list of all the places we knew of RTs working in ambulatory and post-acute care, and there were probably about 30 different spots on there. Organ transplantation, simulation, so many different opportunities for folks. It's not just the bedside. So if there's something in this field that interests you, or something you see nurses do that interests you, that you think RTs can do better, we can. You can make those things happen.
Go get it. That's the
Absolutely.
biggest thing. Don't sit there and wait for something to happen to you. Go make it happen.
And
Love it.
don't be afraid to ask. Again, a big part of the reason that I got to where I am is I had so many good mentors and sponsors and examples and everything else. And everybody I've ever met has been so willing to share their experience and sit down and say, "Hey, let's talk for a half hour or an hour." I've learned. There's guy. Can I do a shout out real quick?
Yeah, I was actually
Yes,
just
you
gonna
can.
say we end the show like typically with shout outs. So any birthday celebration, graduation, mentor, please, yes, shout outs.
So again, I knew virtually nothing about oxygen when I came in. My boss said, "Well, I want you to run our oxygen program." I was like, "Okay, cool. It'll be a good challenge." And again, I wanted to kind of stretch and grow a little bit. And I had no idea what I was getting into. I had no idea how much I didn't know. But a gentleman by the name of Joe Lewarski, who has been again, he's done almost everything in DME. He's been a department director in inpatient. He's run his own DME. He works in industry now. He works for one of the manufacturers. I was able to connect with him, and he has given me literally hours of his time to teach me, okay, this is how we got from A to B. I had mentioned I put together a timeline of how oxygen fell apart, and he was like, this is great, but this is only like step one. Let me take you back. And we set up these hour-long meetings and then end up talking for like 2 and 3 hours, because he has so much to teach, and he's so willing to teach, and he's so good at it. I've had a lot of people like that, fortunately, in my life. So, as you young or even seasoned RTs looking for a new experience, if you want to do something, like I said, first of all, remember that you can do it. They are out there. And then find somebody who is in that area, or is at least adjacent to that area, and find out what they can tell you, because I have never run into anybody who didn't want to share.
Wow. Mike, thank you
Love it.
so much. That is also perfect segue into the shout outs as we wrap up this episode. Again, in the show notes, there's another link. If you have a shout out, we'd love to give you one here on the podcast, but there's just so many things, that you can do as an RT, or you could even just share this episode with someone who you know who's struggling with this condition, so that they know they're not alone and there's a whole community here for them. I want to give my shout out today to Eileen Sorty. It's her 80th birthday. She's moving from Colorado to the East Coast because she has low oxygen, and the high altitude of Colorado
Oh,
is really difficult. And so she is now trying to face and navigate this problem of oxygen therapy in the US. And a very timely episode of that today. So happy birthday and good luck with the move. Matt, any shout outs?
my big shout out to Mike today. One thing that you're doing is you're trying to make COPD sexy, and that's going to help save a lot of lives. So thank you for all the work that you're doing, and all the RTs that are supporting patients with COPD, because it's a big deal and it's a big part of our country. So thank you.
Mike,
Absolutely.
anyone else? Any other shout outs you'd like to give or last thoughts?
Uh, um, Honestly, I'd love to shout out all of my friends in ambulatory and post-acute care, DME, pulmonary rehab, again, all the other areas I've mentioned. I firmly believe that this is a huge part of our future as a profession, and I'm really looking forward to working with everybody to bring this forward, and to really to turn a new page for RT in general. So reach out to me anytime, join our section. We got to grow it, and we'll see you at Congress.
And
Love it, buddy.
happy World O2 Day here coming up. Vapotherm does not practice medicine or provide medical services or advice. Any clinical recommendations provided herein are solely those of the speaker. Practitioners should refer to the full indications for use and operating instructions of any products referenced before use. Pelvichco and Hayes are employees of Vapotherm. Butler is a paid consultant, and our guest is not compensated.